Hello everyone. This panel discussion is a continuity of our previous discussion on the same topic. So if you haven't watched the previous one yet, you can go back and view it on our Physio TV YouTube channel. Thank you.
We will now, I would now request John to take over and present the case that he would like to share with us.
Thank you, ma'am. I'll just share my screen. Yeah. Okay, is my screen visible?
Yes.
Okay. Thank you very much. First of all, I would like to extend my thanks to Sancheti, the entire team, Sona ma'am, Dhara ma'am, Franny for coordinating this event. I would like to also take this opportunity to thank especially Sancheti for the opportunity that they gave me way back in 2006. That was my first talk on vestibular rehabilitation outside my institution. So from then I went on to do many more workshops and other things, but my starting point outside Mahe was at Sancheti. And today I'm going to discuss a particular case. This is not a new case; it's a very old case that I have taken up. But this is a case we saw in 2009. But why I picked up this case was that after this case, till then there was no practice of vestibular rehab in the neurosurgery ward. But after this case, it initiated us to trial pilot RCT. And then that we were able to show a difference. There was an evidence that it works. And we even presented this in the International Physiotherapy Conference in 2011 in Ames, which won the Best Paper Award. But for all that, the precursor was this case and the clinical reasoning and how we were able to convince the clinicians on this and keep the patient for rehab in such cases. Has changed our practice. Then after that, for the next 1 decade now, we are continuing to see many more cases like this, but this was the start. So I'll be happy to discuss that case now. I would have not. This is about a 35-year-old male farmer. He sustained a traumatic brain injury while he was driving a bike. He skid and fell, landed on his right side, injuring his skull as well as his shoulder region. He was brought to and lost consciousness, and he was brought to the hospital by the bystanders. And when they did the examination, they found a fracture in the temporal bone and also a neck of humerus fracture. And the patient was treated conservatively. Luckily, he didn't have any major bleed inside, like an extradural or anything. They were waiting for it. They wanted to see a scan after 24 hours. They did take. Thankfully, it was not. And the patient also regained consciousness. But then actually came in the evening, and by next day morning, he regained consciousness. And there was no major neurological deficit at that time noted, so they started him on conservative management. Patient was in the ICU for 48 hours, and then he was shifted to the ward and was examined, and he was referred for physiotherapy, mainly because the patient had balance problems. So when we saw the patient was conscious, cooperative. His main complaints was, he said, dizziness. And here it's very common for everything. I'm sure even in your region you might come over. It's always in southern India, talasuttu at chakkar, but that involves so many, it can be anything. So, and after a head injury, dizziness seems to be common. Often, sometimes it's a transient thing that goes off. But in this case, he was very specific about having dizziness when coming, when turning and coming, when he was getting up from the bed and sitting or turning, moving the head. Otherwise, he wasn't feeling that dizzy. And he was unable to walk independently. And despite no obvious weakness in the extremities. So we went ahead to evaluate the patient, and so our question was, the first question was, what is what? When you say dizziness, what it is? And as Dhara ma'am, as you spoke in the beginning, it can be many things. So we kept asking, what exactly is he feeling? And then this patient was, though uneducated, was quite an intelligent patient and was able to understand. He did say that I see, I mean, things moving. When I move my head and I stop, I see things, everything moving. So it was more of objective vertigo that he had. So we decided that it could be a post-traumatic vertigo, and we wanted to know what causes it. So we want, what type of treatment should we go ahead with this patient. Now, when we talk about vertigo after TBI, it can be due to injury to any of the three areas, that is in the peripheral vestibular system, either in the apparatus, the nerve, or in the central nervous system, including the vestibular nucleus and its connections. So if we take vestibular apparatus, even BPPV can be caused after a trauma, especially in many mild to moderate TBI. We do come across patients having vertigo because of BPPV. So what happens is when they hit, the impact causes the autoconias to dislodge and enter into one of the semicircular canals. And then the patient has a typical BPPV where they complain of in lying, turning around to either side, lasting for not more than a minute or two. So it's very typical and easy to pick up. And as Priti described in her case, we go ahead in managing the patient with one of the maneuvers. But the other ones are more not that common, but it also could be the reasons for post-traumatic vertigo. The impact sometimes can not just dislodge autoconia, but also actually cause a disruption in the utricle and saccule and its functioning. So what happens is patient finds it difficult in two aspects. One is their postural stability and their visual stabilization, and skew deviation, where one eye is over the other, up and down kind of look, is also common after this dysfunction. And they have what is called as lateropulsion. They tend to lean towards one side like a pusher, but not like a typical pusher, but they tend to lean to any one side more common often. And in this, okay, I will come to the case. And so that could be one of the reason we wanted to rule out otolith dysfunction. The next common cause is the labyrinthine concussion. So that is a impact causing microhemorrhages in the labyrinthine, including the cochlea as well as the membranous labyrinth, that is the vestibular area. And this also can make the patient have similar symptoms of vertigo, often transient, but but has other features like even tinnitus and other ear features are associated with this condition. The next one is sometimes what is called as perilymphatic fistula, where there is a rupture in the bony labyrinth, leading to perilymph coming out of the bony labyrinth, and that causes sudden change in the pressure and leading to severe dizziness. A simple clinical test used to be holding the nose and blowing it, increasing the intraoral pressure, causing the patient to immediately have a lot of dizziness and visible nystagmus used to come in. In these cases, patient has to be kept on bed rest for the membrane to, I mean, the bony labyrinth to close by itself. You don't want the perilymph to keep coming out. Otherwise, in some cases, the surgical interventions are required, but in most cases, bed rest could be adequate. So those were related to the apparatus related injury. And as we move to the nerve, usually nerve injuries are not common. It's relatively very rare because they are well preserved in the internal auditory canal as they pass through. And usually, even in not just any temporal bone fracture, the injury happens. So usually when the petrous bone fracture, with that when there is an injury, it can affect the internal, when the impact runs through the internal auditory canal, then the chances of injury to the vestibular nerve is higher. It often injures also the facial nerve, or sometimes even the fifth nerve, because it injures the nerve. It not just specific to the vestibular nerve, but also the cochlear component in this region. So often the hearing loss of nerve base is also common in these conditions. Now, the other cause could be in terms of patient having any lesion in the central regions. It could be the nucleus, the cerebellum, sometimes even injury to the inferior cerebellar peduncle, and rarely also sometimes in the cortical region, vestibular cortex can have it. In terms of vestibular cerebellum and the vestibular nucleus, there is vertigo as a major symptom, along with balance disturbance. But inferior cerebellar peduncle injuries patients usually don't complain of vertigo, but often related to imbalance. And vestibular cortex patients can present with problems in perception of verticality and difficulty in balancing, and like lateral pulsion can be there. So these were the major symptoms, and usually associated with along with some other central nervous system features. So it's not so sometimes very localized in vestibular cortex injury and all. So usually some other higher mental functions also. So in this case, we had to check all these things, and we went ahead evaluating this patient. The patient, when you looked at him, he was able to sit straight. There was no lateral pulsion. He was sitting vertical. And actually his static stability was good in sitting, as well as tonics and eyes open standing, which I'll come to later. But when we asked, there was no spontaneous nystagmus at rest, but when he was trying to look towards the right side, there was a nystagmus that was appearing. And along with that, the patient also had a right-sided facial nerve palsy. So he was unable to make expressions on the right side, whereas the left side was active. So in further examination, in terms of neurological examination, he did not have any other sensory motor deficits, no signs of incoordination in terms of non-equilibrium tests, tests. All that was normal, and he was able to use his left limb well. The right limb was on the pass, so we were able to not do the test properly, but we were able to do it only in the hand, but his fine motor functions were pretty good. Now, when we made to walk, he was unable to walk independently and used to sway towards the right side while walking. He used to have this cast in his hand and used to hold on to something. The minute he leaves, he used to tend to walk, move towards the right side and lose balance. So someone has to be there by his side always. And so when we ruled other thing before we went ahead with further testing, we also did a positional test to check for BPPV, and it was negative. And in terms of his vertigo and his imbalance, we further wanted to examine his vestibular motor output systems, that is mainly the ocular system and the spinal reflex systems. So the first one was, this is a patient who was just for feeling vertigo, and we used VAS in this case. So we asked the patient to rate, just like pain, on head movements, what is the amount of dizziness that they are feeling, and that they have to rate it. So this is what we used at that time. As I told you, it's a really old case. I'll come to discussing about outcome measures, other things later. The second one we did was to check his vestibular ocular reflex. So he was, even for a slow movement, for him to focus on a point and moving the head, he was missing the target. There was errors every time he was turning to the right, and the head test showed that there was a reduced vestibular gain whenever we moved the head. So it was very clear that there was and more towards the right side again. So it was very clear that there was a unilateral vestibular dysfunction. And we also saw the patient, we made the patient sit on a vestibular ball and checked static balance was good. So we could make him sit, and then we tried to tilt the vestibular ball and see his vestibular spinal reflexes with eyes open and eyes closed. Even for eyes open, his reactions were very less. He was unable to create appropriate reaction, and he used to lose balance in that. So we also went ahead and testing, doing a modified clinical test for sensory interaction for balance. Here, the patient had to stand in 4 conditions. So eyes open standing, he was stable. And when eyes closed standing came, he started swaying. So similar to a Romberg sign. But our evaluation also revealed that there was not a significant progressive deficit for this patient. So we there, but it is then we asked the patient to stand on a foam. There was a mild sway, and the eyes closed, standing on the foam, the patient was unable to perform at all. He used to, the minute he closed standing, and then we asked him now close the eyes, he lose the balance. So it was quite difficult for the patient, and it was significant that usually the last condition, that is eyes closed, standing on the foam, puts a lot of requirement for the vestibular system to create appropriate reaction. And when that is not functioning well, usually the patients are unable to maintain balance, and that was seen in this patient. So we ruled out BPPV. We were sure about it. We did not find any other associated central lesions such as diplopia or dysphagia or anything relating to the brainstem, and there was no incoordination or anything related to the cerebellum. So we ruled out that. We were not sure about vestibular concussion. We were sure it was not a no perilymphatic fistula. So we were mostly thinking between vestibular nerve injury or a vestibular concussion kind of thing. But we had to do another test. Anyway, in the gait, we had at that point used the dynamic gait index, and the patient was finding it very difficult even for a level surface to walk independently, and could not do any of the other things such as walking with head turns, look up and down, or move, negotiating obstacles. All this he was unable to do. So finally, as I said, the question came down to the concussion or the nerve injury. We're thankful for the ENT at that time. We had a very cooperative ENT surgeon who helped us to do the caloric test to check, and there was no response from the right side, confirming a vestibular nerve injury, and which was just resulted in the unilateral vestibular dysfunction, and with a right element facial palsy. So leaving out the facial palsy, so our focus here we will discuss how we went ahead with treating the unilateral vestibular hypofunction. We started with adaptation exercises. It's similar to how we treat the neuritis case. So the idea is to induce as much as adaptation through gaze stability. The main focus is to ask the patient to focus on something and move the head. And every time the patient misses the target, that he knows the image slip that happens in the retina, that acts as an error signal. And to do this, one of the important thing is that vestibular adaptation exercise to work in these cases is to have an intact cerebellum, because the corrective mechanism has been hypothesized to happen through the cerebellum. So the descending signals from the cerebellum, which whenever there is an error, the cerebellum tries to correct the signals at the vestibular nucleus. So this correction is called as the teaching line. And every time when you keep learning to focus, the cerebellum keeps correcting the vestibular nucleus firing, and eventually able to ensure that the gaze stability is appropriate for that particular speed in which the training has happened. So it's important when we develop exercises, we keep this in mind and appropriately develop exercises. We can use any of the stimulus for the patient to focus. It can be a letter written on the card, preferably of a particular size that is clear enough for them to see. It should not be too big or too small. Or if this doesn't work for many of the time, we just ask the patient to look at the base of the thumbnail. Hold it in front and look at the base of the thumbnail. Or you can even use monitor now, for example, looking at doing telehealth, looking at a monitor and doing, or that can be just a natural environment, looking at a switch that is far away as well. So a proper stimulus where the patient can focus something clearly, and we ask the patient to start moving the head with slow movements and ensure that the gaze fixation is there always. Usually that is where they go wrong. They keep tending to start and then they will lose the focus on focusing on a particular target. Often the therapist supervision is required there to keep giving them the feedback to get back to the focus. And these exercises, we ask them to not do just in one particular speed, but different speed, not so some in medium, some a little quicker, but ensuring that the still the what we see is clear, because the adaptation is also velocity specific. So it gets adapted only to the speeds in which we are training. So if we don't train them at a quick speed, and then at one point they go have to cross the road and then suddenly make a quick speed, at that moment the system is not ready to fix the gaze well, and the image slip will happen. So we need to ensure that the patients are trained across different frequencies in the 3 to 4 weeks. And you did say this about this, Dharam, that it has to be performed at their limits of ability, and not just in one position, but in sitting, standing as a progression, if possible, on standing on a pillow to get the uneven surface things can be done. And usually we encourage them to do 3 times a day, basically to increase the number of repetitions. The idea usually is that the first week we give the patient to do exercises on their own. When we come to, in this case, we started to do exercises on vestibular ball or soggy foam, also they can do the exercises. And then start gradually move to walking with looking at a point. And if possible, if they are steady, then we can move, ask them to keep looking at a point, move the head and walk, or shift the gaze between 2 points and walk as progression. For in this case, we were able to do only till walking with gaze on a fixed point. So at the end of 1 week, when we, I'm sorry, the VAS score is, it was 7 out of 10 at the end of the 7th day. And they had a improved vestibular gain. And the patient was able to create appropriate reactions. End of the the 1 week, the patient's standing ability improved in all the 3 stages except the 4th stage. Still, he was not unable to stand independently. He required more time. But by the time the patient had to get discharged, we had to keep him on the hospital just for this for close to, we started on the 2nd day to 7th day, almost was about 8 to 9 days from this day of admission by that time. So after, at the end of, when he was going to get discharged, his dynamic gait index had improved quite a bit. He was able to walk independently, but changing speed or moving the head and walking were a little difficult for him. And he was not able to, at the end, also do stairs on. So, but we found that, okay, so we knew from this case the vestibular nerve injury could be one of the cause at that point, and that vestibular adaptation exercises were working to improve the patient's ability. And that's when we moved to the next phase where we did the pilot RCT for seeing post-traumatic vertigo for a 2-week program, and after that a 1-month follow-up. And we did see a good difference in patients who underwent the vestibular rehabilitation. And since then, we have been practicing this protocol in our hospital, and so far we have been having a good success with the most of the cases. So that's about this patient.
Oh, that was great. Thank you. John, it was really nice that you took us stepwise through understanding the different steps when planning the treatment program and how do we progress, what are the things that we actually look at. I was just, as I was listening to you, the one thing that really struck me was that you mentioned that at the 7th day, the VAS was a 7 on 10. So that had not really changed from the first day. but the DGI showed a 10-point change. And we know that research shows us, or has found, that the minimum detectable change for DGI is about 4 points, when you can be 95% confident that there has definitely been a change in function. So I thought so.
My mistake. Actually, the 7 on 10 was the baseline, and yes, sorry, it was not a mistake. Actually, he did improve
It did.
from
Okay.
7 to 2. Yeah, it says
Yeah.
suddenly I remembered 7, and somehow I said it
Oh,
is
no, that's okay.
from 7 to 2. Yes.
Lovely.
So his
So we
dizziness
know that.
had come down with the movement. Yes, exactly.
So exactly, because I like to know that subjectively the patient perceived that change, and objectively we saw it on DGI. So
Yes.
I mean, that's a great way to know that things were working and that what you were doing was along the right track. The other thing I would like to ask you is, this patient was sent home after 7 days. Did you put him on a home exercise program? Did you have any further follow-ups with him?
Yes. So we had given him the set of exercises that he has to do. So we wrote down at that point what all exercises he have to do, how to progress for a 4-week period, and we wanted to have a follow up at the end of 1 month, and we had asked the patient to come back. But unfortunately, we did not have couldn't get the patient back for the follow up in this particular case.
Okay.
So over telephonically, we could contact. He said he's fine, and he did never turn back for the follow up because they live a little far away, and he has gone back to his routine. So we couldn't get back his thing. But the other cases in our study had a relatively good follow up, and there we have seen that the patients do exercises regularly. We had mechanisms to remind them every 1 week, calling them and reminding them do the exercises. And most of them did come back in that case to the study. But in this patient, we had lost the follow-up.
Okay. So I mean, the point was, obviously we want to know what happened later, but also to understand that how much. So if I have to tell my patient that, you're going to take, say, X number of weeks to get better, what that X number would be. Like, in your experience, how much time does it usually take for the adaptation to occur so that patient returns to pre-morbid functional state?
Yeah, so usually in case of hypofunction, unilateral vestibular hypofunction, it's about 4 to 6 weeks. So we get to see a good change between 2 to 3 weeks, but for them to get adapted to high velocity movements and incorporate recreation and other activities, and they getting good confidence, we will go up to 6 weeks. So 4 to 6 weeks would be a
It would be
time.
the appropriate. Oh, wonderful. I mean, it's always nice to know as a clinician what I'm looking out for when I am, giving this treatment program, and knowing the time it will take to take effect. So that really helps. Thank you so much. And I would now also like to ask Priti if she would like to have, whether she has any comments on, the assessment, the treatment, anything that you would like to add to what is already said.
Just one question. So I think so. We saw some spontaneous nystagmus in this patient, right, sir?
I know. Actually, when we saw, we could not see much. It was more towards when he started moving towards the right side. We were seeing it, and at that time we did not have a Frenzel glass, or video nystagmusography was not there with us. So at rest, we did not appreciate a nystagmus at that point.
Okay.
But I suppose if we had Frenzel glass, maybe we would have seen it actually.
So does that point, sorry to interrupt, but does that point to the fact that maybe he was able to fixate when he was,
yeah,
and that's why we couldn't see the spontaneous, and that again points towards the fact that this may not have been a central problem, because we know that, fixation will allow you to suppress your view.
Thank you, sir.
Okay, great. And I would also like to ask Ritu to add to the discussion, if there is anything.
Thank you so much. What an interesting case. I loved listening to you, Dr. John. So couple of questions. I know you had labyrinthine concussion in your differential diagnosis. Because this patient had a temporal bone injury, did you think about brain concussion, like traumatic brain injury? How did you rule that out? Because usually, MRI and CT might not show anything.
So probably I do believe the patient did have a brain concussion as well, because there was no anatomical disruption seen in the CT, but he had a loss of consciousness for close to 6 to 8 hours. So I do expect the patient to have a brain concussion, and possibly even the patient might have had a vestibular concussion. But when injury plus concussion is there, it's very difficult to probably differentiate. It probably is there, but with the caloric test, we are able to pick it up as a nerve injury. But probably even if the concussion it would have been there, we don't know how to differentiate it. It might have been there in this case, actually.
How was his saccade, smooth pursue, all the central oculomotor exam that we do? I mean, I know you had a lot going on with that case.
So when we looked at smooth pursuit, it was smooth. There was not much of a problem, and but there were saccadic responses when we moved towards the right side slightly. But I actually don't remember it that much. What exactly happens in the long? Somehow I did this particular case. I documented and kept very carefully. But this point, I don't remember exactly what was there at that point of time.
Yeah, but I think Ritu brings up a good point that one of the ways that we could actually know the difference would be if, we looked at the oculomotor exam very closely, especially because your gaze system has a number of components, of which the vestibular system is one. So we need to and all the other systems are the higher centers. So if we can, kind of just very specifically tease out, which system may be involved. And like you said, there could be a mixed picture. And I'm so happy that this particular patient had more of a peripheral kind of involvement, and we saw the changes we did. But yeah, I mean,
yeah, that's true. So that's why majority, as you said, it's rare that we do get a lot of mixed pictures. And so as you said, it's very important to ensure checking the optokinetic system and the central mechanisms to ensure that it's actually purely peripheral or purely central. Sometimes it's very difficult to differentiate.
Right. But it's great to know. And yeah, go ahead.
I have one more question. As a clinician, I'm curious, how you said you have to train the VOR at a specific speed in order to see a functional change. I absolutely love that, and I can't agree enough. But it's easier for people with smartphone who can download a metronome app and just turn it on and do their exercise. How do you do this in a farmer? I'm just curious, like who wouldn't have
that? I think we just say slow speed, normal speed, high speed, like that, in that kind of thing. But as you said, now we have started using metronome when we are doing at the hospital setups, but it is otherwise difficult to teach them. It is just that do it fast, Begamadi. But you have to see, the only thing, the problem usually happens is the minute they start doing it fast, they will lose the focus. They focus on the point, and once you stop focusing, the whole point of view, the adaptation goes off. So only that we may have to keep insisting on that.
True. That's a great question too. Yeah.
So one question. So you did the caloric testing for this patient and it was complete loss, right? So we had completely lost that function. So I'm impressed that his improvement was significant at that level with complete loss of function on one side.
Yeah.
So that's quite...
So I think that's because that possibly was because of the compensation from the other side, the normal side, and surprising that's why I feel even though he did gain, especially the vertigo came down and his balance improved. In 1 week period, it still was not that well. I think in most of our cases that we saw later, took easily about 3 to 4 weeks for them to really improve over time, actually.
So caloric testing also only tests the horizontal canal. It does not test the anterior and posterior canal function. So probably we just got that, so probably it's just the superior division of the vestibular nerve got affected and the inferior division was spared, and that's why he was able to recover faster than what we are thinking.
Maybe possible.
Those are great possibilities. Yes.
Mhm.
I think this has been amazing. So far, obviously, we've seen the cases where there was actual structural involvement of the
Mhm.
vestibular systems. And now we have a very interesting case study that Ritu will be presenting to us, which is about this new functional disorder. I think some of us must have heard of it, but it's the 3PD. And Ritu, please take over and enlighten us.
Thank you for keeping up. Whoever has scrolled this video till here. Okay, all right. So let me go into this present mode. A little bit about me. I am a Sancheti graduate since 2006. I've done some education at Mass General, Emory University, Atlanta, online in the past pandemic through APTA. We couldn't go to University of Pitt in person. And again, I'm enrolled in another University of Pitt course. So I think this is going to be lifelong passion for me. So Agile, Sancheti, Mass General, Emory, these institutions are really close to my heart. And thank you for all the you connect me back to my passion. One of the things our team has done in the past is build a vestibular telehealth course offered by Agile Physical Therapy, and the link to that is on my LinkedIn profile. So I highly recommend taking a look into it, because like in the previous case, I know he's a farmer, but he couldn't come back due to some or other reason. And just a virtual visit is such a good option to check in with your patient. So I highly recommend keeping in touch with people in case like life comes in the way and they cannot make it. All right, going to our case 4. Emily. Emily was a 36-year-old female with complaints of chronic dizziness, unsteadiness, neck pain since 2 years, has seen multiple doctors, various primary care physicians, chiropractors, ENTs, and she showed up quite frustrated in the outpatient visit that I had, where she continued to feel unsteadiness and didn't have confidence in physical. So she absolutely did not exercise due to the fear of vertigo. And her medical tests, MRI and CT, were negative. So she couldn't like pin down on something that she could blame on in terms of her vertigo symptoms. And her symptoms started about 2 years ago. She had a BPPV event, and she got better, and then again she had some BPPV event, and after that she just didn't trust the epi and didn't follow up with their doctors. However, currently, when I deep dove a little bit into what she is experiencing, when I didn't let her use the word dizziness, she said this is a non-spinning vertigo. That means her environment moves, it's unsteadiness, and she has extreme nervousness to go out of her house. So again, like I said, outcome measures, her activities of balance specific confidence score was 44% over 100. And she had no history of falls or near falls. She would just be extra cautious. Her DHI, dizziness handicap inventory, was pretty high, 70 over 100. She had, like I said, neck pain since 2 years with limited range of motion. She denied any headache, phonophobia and photophobia, so no light sound sensitivity present. She also reported disturbed sleep because of worries, and so lack of exercise, disturbed sleep. Just I'm thinking about it as a biopsychosocial model, not just asking about the symptoms is what I covered with her. So this is something that Dhara ma'am has already covered, but I want to just kind of refresh. It's really important to deep dive and ask, what are they experiencing? And I tell them, what if I didn't let you use the word dizziness? And they usually describe vertigo as any sensation of movement when it's not occurring. Okay, so sometimes they feel, why is my environment moving, or I feel like I am moving. Unsteadiness is just general instability or disequilibrium, and dizziness is basically not having vertigo or unsteadiness. And I also ask, do you have like a syncopal event or lightheadedness, or like you'll pass out? And sometimes there's like a myriad of symptoms, and there is permutations and combinations of these words. So it's really important, like John sir said, like every speaker here has said, to really ask, what are they experiencing? These are some really high power tests that we have in our hands, and I really want to encourage every clinician to do them. We have oculomotor exam in room light, which does not require any Frenzel lenses, and BPPV testing. And of course, we have Frenzel's exam, but sometimes it's just not possible to get that. So these are some basic tests that I did on this particular patient. And along with, so most of these tests were negative. Actually, all of them were negative, except DVA. That was the one that was positive for this patient. Just a little bit about HINS exam. This is again a very powerful 3-test bedside exam that helps us identify any central case. So you want to first do a head impulse test that was demonstrated in a video by Priti. If the head impulse is normal, that's a problem, okay? Because you can't blame it on your peripheral vestibular system. If you have fast-paced alternating nystagmus, which means that the nystagmus is changing directions, that's problematic again. And the test of skew, that is refixation on cover test, that means the eye is refixating. If these 3 tests are positive, a clinician should always keep in mind that there could be possible central event going on, and you could refer this person to the neurologist or the nearest emergency. Just being cautious. And these tests are Newman and Toker identified in 2009, that's 100% sensitive and 96% specific. And so really important to not miss that in an acute vertigo case. So in this particular patient, like I said, negative oculomotor exam, HINS exam was negative BPPV testing, although she had positive balance issues, which means when John sir will start describing modified clinical test of sensory integration and balance, the 4 conditions in which they stand with feet closed without a foam, and then feet closed on the foam, eyes open, eyes closed. This particular patient was swaying a lot in the first condition itself. She had, she could continue for 30 seconds, but after that, she just refused to participate on the foam. She was just too scared and almost kind of sweating, and her skin color was changing during the testing. So I, of course, did not push her because she was already uncomfortable. Her single leg balance, eyes closed, was just 2 seconds. And then she just, again, refused further testing on balance. So before I saw this patient, like I said, I always look at the dizziness handicap inventory. And there was a cool 2021 recent study that showed that just having a look at DHI helps you categorize some vestibular diagnosis. And if there is a DHI score over 60, there is an increased possibility of functional disorders with a pretty good specificity. And under 30 is mostly structural problems. And in a bit, I'm going to come to actual pathophysiology of this, but it's just such a powerful questionnaire that can be used in our clinical practice. And I tell my patients, I'm going to get a lot of information from this. So please take 5 minutes prior to your appointment time to complete this ahead of time. So I actually would request all of you all to find a way to convince your patient to complete it, even if they don't feel great. They don't feel good about doing this all the time. So what was I thinking? Like I said, what are the possibilities for Emily? Because there is no oculomotor exam. The oculomotor exam is negative, HINS is negative, BPPV is negative. There is no phonophobia. What is going on? So what I was thinking about is, how about 3PD? So this is a quick definition of 3PD, that is a chronic functional disorder of nervous system categorized by non-spinning vertigo and perceived unsteadiness. Symptoms are exaggerated by upright posture and exposure to visually complex environments such as supermarkets, cinema halls, shopping center, or any other intense visual environment. She actually hated my shirt too because it was too many patterns. So then comes to sometimes, like, we want to also clarify this, that this is not a psychiatric syndrome. They are not imagining this. It is a very behaviorally conditioned response where the CNS gets reorganized, and it's usually present with comorbid anxiety, which was very evident in this patient. She was swearing by the time her modified CAT-SIV went to the next level. Other synonyms for 3PD are chronic subjective dizziness or phobic postural vertigo. And this is often a term used that it's really in your head, but not like what you think, is what they say in literature. And sometimes I do explain it this way, where there is problem in the functioning of CNS rather than a diseased process. And let's kind of try to understand the interrelationship between physiological and psychological factors in dizziness. So on the left-hand side, because they both can come to the same end point of having a neurosensory disease, or, I hate the word disease, but dysfunction rather. Okay, so on the left-hand side are a list of structural problems. And if there is any coexisting primary psychological disorder, so for example, if this person is already an anxious kind or who worries, or it has something else going on, or is depressed, that can lead to a combination of altered physiology as well as abnormal response to normal body sensation that leads to these dizziness syndromes. And on top of that, if there is a secondary, which can definitely amplify the psychological problem, which make it a secondary psychological symptoms, which leads to problems with chronic dizziness. So I really like how this particular explanation was done a while ago. I know it's 1994, but Dr. Janine Homework presented this in 2018. Again, just kind of bringing that concept back to us. So I know this has been explained in the beginning of this introduction, but I'm going to still go ahead and explain how does the normal model of balance system get affected in patient with 3PD. So normally we get information from a somatosensory system, labyrinth, and vision that goes to the cerebellum and cortex, where the movement gets refined and then it's reproduced as VSR, VOR, and OTR. So vestibular spinal, vestibular ocular, and ocular tilt response. What happens in a patient with 3PD, that they perceived, so basically amygdala is stimulated and they feel like it's a threat to their system, which stimulates the autonomic response. And that leads to heightened awareness, where they are conscious about their motor control, and they can go into a flight or fright response with increased heart rate and blood pressure. In this particular patient, I saw sweating with just a balance test. So that was one thing I was thinking about. The other thing I was thinking about is neck pain. This patient has neck pain for 2 years, and she's having limited range of motion. So I wanted to not forget cervicogenic dizziness. So what is cervicogenic dizziness? It's a diagnosis of exclusion, which means we should differentiate it from all the conditions listed below, and then there are no basically diagnostic tests to identify. This is like a confirmatory test. So for example, we have head impulse test that tells us, oh, this is vestibular hyperfunction. We don't have any diagnostic test here. So we need to conduct a detailed subjective and an objective exam to eliminate other reasons of dizziness before we say it's cervicogenic. So it is really crucial for physical therapists to do a good job with history taking, subjective exam, and objective exam. So like I said, Similarly, this particular patient, we made sure there's no red flags, which means no 5 Ds and 3 Ns. If you want, I can review that. Detailed timing and triggers. Wanted to know what really triggers her symptoms. So upright positions, when she would refuse to go out, she would refuse to, like when her neck would hurt, she would have more symptoms. So trying to identify what really is triggering the symptom. We measured her functional limitation with ABC and DHI. Also quality of life, because that matters a lot. Getting their sleep, exercise routines, and all of that information is very important. Followed by that, we did a detailed exam. We ruled out other central conditions and of course BPPV, because she was annoyed how everybody was telling her she had BPPV again. So that again was getting into this anxiety plus a little bit of an angry mode, and then just understanding that we need to rule out everything else before we blame it on the neck. So coming back to Emily a little bit. So her nature of complaint was non-spinning vertigo. During her DVA test, she lost 6 lines. So her DVA score was 0.6. Normal should be 0.2. On further examination, VBI test was negative. Deep neck flexor endurance test was 7 seconds. Normal is 29.4 in females. Her cervical joint position error, basically we to put the laser, gave her the joint position error chart and have her close her eyes and come back. She was 6 degrees. So she was in the red zone with that particular test as well. So here I was thinking that there could be a possible combination of 3PD plus cervicogenic dizziness because of involvement of C-spine along with weakness of DNF and positive joint positional error. And even patients with cervicogenic dizziness can have this unsteadiness that I hear a lot during this, specifically worse during the pandemic, where we have all been a little bit more on the computers. So I was thinking it is that. Okay, so coming to the treatment approach, I'm blessed to work in a multidisciplinary location, and it's important for a patient to know that we can work in teams. It's important for us as vestibular physical therapists to know that we can work in teams. And I highly recommend that, because then you use best of all. So what was done for this particular patient? So Emily was seen by a psychologist who was trained in CBT, cognitive behavioral therapy, who helped her with calming her anxiety down, giving her relaxation, breathing techniques. I mean, this can be done by a physical therapist as well, but it was just a good help in the team to have somebody else cover the psychology part of it. She went over the grounding techniques like Priti was covering, and just having her lessen her fears and slowly expose her, keeping her anxiety down and giving her some real-time techniques to calm herself during a threat that she perceives to her system. We also had an otolaryngologist from Stanford participate in this particular case, because she again helped with detailed caloric testing, all the stuff that we needed to confirm the diagnosis, and a little bit of medication support that Emily needed in the beginning. And vestibular PT consisted of education. I think that was the biggest piece for her, is to know that she's not imagining, to not feel that she has to justify herself, or people would judge that she is, that malingering. So I think that was a relief for her, is getting educated. The other one was treatment of neck pain. We included that in her follow-ups, where we did manual therapy, deep neck flexor strength and endurance training, and laser training. Coming to the vestibular part, we did gaze stabilization, where moving from a plain background to a complex background. So we had her start with like a plain wall with a solid color to a checkered table cover on the wall, and she's doing gaze stabilization, which was very hard. So we had to choose easier patterns first before going into a complex background. She also did visual motion desensitization. So getting exposed to complex environment like grocery stores, teaching her how to create an eye target so that she can navigate through a grocery store without freezing or having a panic attack right there. Habituation, again, getting used to movement was the biggest part here, where we did a MSQ in the follow-up visits, and she got better on paper. So she felt a little bit better about doing these exercises because she saw some improvement. And then we worked on overall fitness and conditioning because she absolutely refused to exercise. So we started her on a stationary bike, 30 minutes a day, every day for the neuroplasticity to happen. Balance training, again, was from simple environments to complex environments, where we had to systematically expose her to the environment. I want to open the floor for some questions right now. Anybody has any questions for me?
Oh, okay, that was great. Awesome amount of information. I'm also trying to take it all in. But there are just something that just occurred to me. One question that I have is with respect to this whole functional disorder. So would we consider things, so are there other disorders that we come across, like your vestibular migraine or maybe gastric vertigo? Would that also fit a picture like 3PD according to you?
So, so 3PD has actually, I have some extra slides where I have listed what is the diagnostic criteria of 3PD. How do we say this patient possibly has 3PD? Where there's dizziness, non-spinning vertigo, more than 50% of time going on for 3 months. This is persistent, may wax and wane, but this patient had like persistent symptoms every day, and fuzziness, heaviness, spatial orientation, unsteadiness, and non-spinning vertigo. And I'll let everybody read that. I don't want to read my slide, but there are like, so that's just A, okay? B is upright posture is exaggerative, which means they don't like that. Moving visual stimuli, complex pattern, she absolutely hated that, which is why she refused to get out of her house or to go into any complex environment. And then something acute triggers it. So, which was again the case for her. And then significant distress, symptoms not attributed to any other. So she was frustrated where nobody could she's been to so many doctors and nobody could pin down, and she was quite frustrated with that. So just a little bit about 3PD, and I found this pretty interesting, and I think I stole it from an article that's listed over here. Basically, what happens is there is some kind of structural event that happens in that's responsible for this particular patient, right? Or any kind of problem. So it could be like a vestibular hypofunction that Priti presented in the beginning, the patient with vestibular hypofunction. So there is some structural event. If there is underlying personality traits of anxiety, pre-existing anxiety or worry, that makes it harder, that makes it like a comorbid psychological condition where we categorize it as functional problem or 3PD. It's just the way their body responds. So it's important to, if you have like B, education is such a powerful tool that physical therapists have when A happens. Does that make sense? So if you know the person in front of you is highly fearful, you want to be careful about the words you're using and educate them with facts, with ensuring that this will get better, and that helps to not transition into 3PD. So that initial touch point that you have with that acute vestibular patient is so critical. And I think they look up to us as the final verdict. So if somebody says that you might not get better or you have to live with this, or then it's really discouraging for them. So I think like we should be careful with what we say to anybody, for that matter, any diagnosis, because you really don't want things to become to add to their worries. They're seeing you to reduce their worries, not to increase their worries. So that is what like 3PD is. And because this patient did not have any migraneous presentation, like no phonophobia, no photophobia, no migraine criteria, I did not think it was migraneous.
Okay. No, I think you make an excellent point, which I hope our audience is able to catch on, that we play an important role in diagnosing, but we also play an important role in telling them what they can expect. And I remember from my master's at MGH, where one of our professors always told us that the first thing as therapists we need to do is calm the autonomic nervous system. And that is a very critical part of what we do in our intervention. And I think one of the ways to do that is to, obviously, like Ritu mentioned, have to educate them well and let them know what they can expect, how long it will take, and so on and so forth. Really good point. I also wanted to talk to you, Ritu, about what happened with this patient. How long did she take to come back to a certain premorbid functional status?
Excellent question. She is actually still under my care since last 3 months. So 12 weeks, but she's doing a lot better. She tolerates me wearing a patterned shirt, and I joke about it, like you hated me when I wore that in the first visit. She also tolerates going independently to grocery store, and she luckily during COVID, she didn't have to expose, but she could control how much she's exposing herself. But she's continuously now working on 3D games. Like she's a high-tech person, so she wants to be able to play a 3D video game or tolerate virtual reality. And I'm connecting her back to her goal of overcoming her fear, as well as gradual systematic exposure, so that she doesn't feel she's alone in this. I think I'm just hand holding. I know it's taking a long time, but she's appreciating how where we started, our goals were get out of the house or just do normal activities, to now recreational goals where she wants to do more. And it's kind of nice to revise your goal and still be help them achieve that.
Absolutely right. I think that's exactly the role we need to play, is handhold when we need to and know when we can let go, and hope we can bring them to that point. And I believe, obviously, it appears that it's been 3 months and you're seeing her, but one must also appreciate from the history that this has been a chronic problem, and that if she has managed it, for about 2 years of going to doctors and, not finding answers, in 3 months is a great time to start seeing results. The chronicity also made me think that, would you think that the cervicogenic dizziness could be a result of this chronicity?
I so love this question.
I just wonder, because I mean, you found that the endurance test was, not even 7 seconds, or about 7 seconds. And so I wonder if this was, again, over a period of time that these things have happened, where now the spine is also adding to the problem. So yes. Another thing that, again, I would like to put out there is that we need to be very good about and that is why that accurate diagnosis and getting them started on the right treatment becomes so important, because then we will also deal with these other problems that may come along the way, because it has become chronic now. I would really also like to hear what Priti and John think about this. Can you please join the discussion?
Thank you so much, Ritu, for presenting such a wonderful case. And although I'm fortunate that I haven't seen a triple PD case myself so far yet, but I've heard from my other colleagues and friends, so similar type. And what I understand from just the mechanism of this definitely requires a multidisciplinary approach. And just a vestibular physiotherapist cannot handle these patients. We need a team approach to help these patients.
Can I say something to that? I feel it's going to be 3x the work if I didn't have a psychologist. But you did the great job by going over grounding techniques with your first patient. And so kudos to you to do it. In spite of that's not something that we learned. So kudos to you to include that when you don't have that other person. I just was fortunate, like I said, to work with the psychologist sitting behind the wall, and we had a pre-existing collaborative relationship.
I have to say, my patient, when I taught him grounding techniques, he was more happy to learn those and perform that than the VOR exercises. He's like, I don't want to do those VOR exercises. I like these breathing techniques and grounding techniques better. I was like, do it. That is best.
I was the bad cop and she was the good cop.
Yeah.
All the roles you play. John, would you like to add something?
Yeah, Ritu, excellent case. I just wanted to ask about the case. One more doubt that I had. I think I understand, but I just wanted to clarify. One is, anyway, mostly it looks like more like a diagnosis of exclusion, isn't it? We were excluding all that, and finally, okay, it doesn't fit anywhere else. Just wanted to know, would you think about bilateral vestibular dysfunction related because of more towards balance, imbalance related, but not much of other issues? So what are the things? I can see a few things, but I would like to hear it from you. What are the things that you targeted that it is not a bilateral dysfunction?
Love that question. So HIT test was negative, both sides. That was a big one, which ruled out, and it has like a positive likelihood ratio of 13.0. So it's a pretty good test to rule in and rule out. So again, I just ruled that out with that, and all other, we had the otolaryngologist who was like the worst cop because she actually exposed her to rotary chair testing and all the tests that would make her more dizzy. But it turned out to be normal. Like, there was nothing structural we could pin down on in the lab testing. The VHIT test was negative. There were nothing that she was blocking due to room light. So it was all negative.
So I think that's great. So I really understand the mechanism, and but as like Priti, I have also not had much experience with triple PD, but hopefully will look for it in the subsequent cases. I think. Great job, Ritu.
Thank you.
Ritu, I am surprised that she's a 36-year-old and she had it was triggered with BPPV, right? So that's something was like, it just like my brain is like, why did she get BPPV when she's just 36-year-old, right?
Such a good question. Such a good question. So, Lou, like when I started launching this program, that was the first thing told to me, like, you work in an on-site company. There is nobody above 65 that works in this company. And why would they get BPPV? Because it's for older women that happens. And it's actually, the prevalence is moving more to the younger age. I see a lot of even 26-year-olds. That was like my youngest BPPV patient that came Friday. And she was just like, why am I getting what 45-year-olds get? And of course, there are like so many factors that lead to BPPV, although 58% of the time, it's idiopathic. We don't even know what's going on. And I'm a big believer of lifestyle factors. So if you are heavily stressed, which often happens where I live, that was like the biggest trigger that I've seen, like especially during this pandemic, quick head injuries or hitting their heads. Also, this group whom I work with is like a very athletic. So if they are bored, they would be participating in like a athletic competition or something. Like these are marathoners. So they are very physically active individuals. at the same time, along with high stress. So a small hit to their head could lead to it. We don't know. It's so common, though. I see it in younger and younger people now.
Yeah, trauma is the main cause of PPPV in younger population. And what I'm reading more is vitamin D3 deficiency.
Yes.
They're showing a direct correlation of having increased incidence of BPPV, because I live in Canada. Winters, and I will see tons of BPPV patients. It just spikes significantly. But obviously, the older population is more affected than the younger one.
Good point. I make sure I ask, how is your vitamin D? I changed my eval template. You know how you put in an evaluation template when you're documenting? Literally, I had to add that question because of everybody being so vitamin D deficient, and not everybody is even aware. They don't get tested. So a lot of times they look at me like, what are you talking about? And so again, being blessed with working with people, so I can tell the PCP, hey, can you please order vitamin D to see what's going on with this person, why at such a young age they're having this.
Mm-hmm.
True. That is an awesome discussion. I think it also tells us that when we are looking after our patients, we need to look at all the possible, understand their physical situation, their social situation, the environment they are in, and the way they're interacting with it. With that, I also would like to now say that I think first I would really want to continue this discussion beyond the case presentations, where in the present COVID scenario, we all have had to distance ourselves and work with patients, virtually. I would really like each of our panel members here to just give us a sense of what their experience has been and what do they think the pros and cons are, and where do we go from here. We can start with John or Ritu, sure.
Yeah.
I'm just pretty curious about this because I personally felt like there was when COVID happened, the medical field, insurance companies finally accepted telehealth. Providers, doctors accepted telehealth, patients accepted telehealth. And for me, for first 4 months, the place I work was shut. There was no other way to continue this without doing telehealth. And when I was looking, there was no course out there that actually outlines systematically how to do this. So our team at Agile got together. This is ortho specialists, neuro specialists, the otolaryngologist at Stanford gave us some very good feedback, and we developed a course for everyone. So it's a self-paced course. You just can do it whenever you want. It has a bunch of videos with the same background because that's where I recorded. But it's basically, I learned a lot. It was a huge learning curve, but it was so exciting that since 1 year, I'm seeing vestibular patients remotely and in person now for certain times. But my patient is sitting in Los Angeles and I am sitting in San Francisco, and I can still conduct a full detailed exam, which is so rewarding to them without they running around in ERs and going to the hospital during the COVID situation. That I'm so thankful for that. And all the DHI, ABC scores, everything is exactly the same as compared to in-person visits. So there has been no change in outcome measures, and insurance companies covering telehealth visit 100%, at least especially with the insurance companies that I work with.
Wow.
I would second everything what Ritu said, and that's how I got inspired and I started my own clinic. It's called Dizziness Rehab, and it's a virtual clinic. And I am limited to see how many provinces. So I currently live in Alberta, so I see patients here, and then I see patients in BC, and I've seen few patients in India too. And that has been very nice connection, so at least I can see them virtually now. And in the beginning, I was a little skeptical because obviously there are some tests that you cannot do, but with the best part about vestibular therapy is 80% of our, the subjective, what patient tells and what patient talks, we are able to at least come to a probable diagnosis with just talking to them. And just 20% of assessment will let us know that, okay, patient has these things, and then we can work in that direction. So that's why I like vestibular rehab so much. Yeah.
Yeah, I would also support the same point. Only thing is, we wish in India the telehealth wise we get the support of insurance, which we haven't got it yet here. As I said, especially related to vestibular rehab, the video calls and examining telehealth really works much better. We had sessions going on for stroke as well as spinal cord injury, but we find it more difficult to do the sessions with them. We need a caregiver, we need someone to ensure their safety and other things. But relatively, when it came to vestibular rehab, it has been much, we could do it in a much safer environment, making them sit on their bed, ensuring that there is chances of fall is very less. And so far it has been rewarding. And as we hope that this situation may be going up and down, and we should be able to adapt to both telehealth as well as the in-person treatment. So
that is so true. I think it is times like these that we actually learn to think out of box and still carry on what we are supposed to continue doing. With this, I really want to first thank all the panel members, Ritu, Priti, John. You guys were amazing, and I really thank you for being so generous about what all you all were doing with your patients and actually taking us through your, clinical decision-making process. I know I have learned a lot, and I'm sure the audience will also learn a lot from this. And that would be all from all of us here. I would like
Sarah, ma'am. Yeah. Sorry, Franny has few questions. So
I was about to take her. Yeah, I would request Franny to take it over now.
All right, thank you very much. First of all, that was a very interesting panel discussion, and all the cases that you presented, they were really wonderful. I just have a few questions to ask. So I'll ask in general, so whoever wants to take it may take it. The first question is, ma'am or sir, is it common to see vertigo with posterior circulation stroke? And are there any challenges we face while treating those patients?
Okay, so posterior circulation strokes do have, some cases do have the vertigo, and most of them, they are central vertigo cases. So usually we need to probably, it starts with difficulty in fixing the gaze as from that point. So there's a combination of habituation and adaptation exercises, and it is also along with pharmacological treatment. Here, pharmacological interventions also are important in these cases. Along with that, a rehab component works. So in our experience, we have been seeing regular brainstem stroke cases with vertigo, which we treat in our acute care setup. And usually the patients have, along with the vertigo, other dysfunctions, such as balance dysfunctions, following dysfunction. So most often it's a comprehensive rehab that goes on for these patients. But it does help the patients as well. Yes, we need to start as early as possible and continue the follow-up for 2 to 4 months.
Love that. One of the things, I don't know if this happens to you, but a lot of times people say, oh, I'm having vertigo. Can I have a quick call with you? And this is something that I want to encourage everybody, is to go through your D's and N's. That means dysphagia, diplopia, dysarthria. You want to really make sure that you're asking the right questions to catch this soon, because like John sir said, there are these important pharmacological management that can actually reduce the damage, and you can catch it early and give them the right treatment and like escalate them if need be, or like, help them when they need be. Again, telehealth is an important tool right there when that happens. But everything else, I 100% agree with John sir.
Yeah.
I just want to add one. Sorry, ma'am.
No, go ahead, Priti.
I just want to add one point, is medical history is so important to just make sure that we do not miss these strokes. So for in my patient, hypertension, hypercholesterolemia, heart problems. Patients have arrhythmias and they can get embolic strokes, posterior circulation stroke, VBI, vertebrobasilar artery insufficiency. These are so important that they'll give you vertigo first. And I just want to quickly mention that I had an experience of vertebral artery dissection in my clinic. That was this patient, not patient actually, one of our colleagues. She got her cervical spine manipulated, not to blame that manipulation can cause that, but cervical spine manipulation. And she started with that extreme dizziness. And I saw that right in front of me. And I was like, oh, wow, now I see what vertebral artery dissection means here. She was taken to the emergency. She was fine. So they were able to manage her conservatively. So these are some most important things that we need to look at our patients. So history, medical history, very important, very, very important. And medications. Yeah.
True. I guess the only thing I wanted to add to what all of these experts said is that we must also know that the feeling of vertigo or even dizziness, which is what usually people will present with, have other origins also. So vestibular system is one of them. And then we also have, neurological, we have cardiovascular. So it is always important to first, very easily know when do you refer and when do you treat. So you should have these red flags where you know that, oh, all of these things are present. The person goes directly to the hospital, gets himself tested for anything really serious occurring. And then if you don't have those red flags, is when you go about your assessment to understand that, okay, where do we go from here? That's the only thing I'd like to add.
I totally second with everyone's thoughts. And that was actually going to be my second question, that are there any red flags or yellow flags that you rule out during your assessment? But thank you, you answered it already. And I totally second with your thoughts, like being a vestibular rehabilitation therapist, it is very important to understand when to treat a patient and when to refer it to ENT specialist or otolaryngologist, and to keep everybody in tune. I totally agree. There's just one more question to Ritu ma'am. Like ma'am, during telehealth, are there any challenges you face for the vestibular rehabilitation?
Yes. So I'll give you a little bit of a structure of how we do a telehealth visit. Okay. Sure. So first, when the patient is booking an appointment, we make sure that they complete DHI, ABC, and an overall functional score to know what are they able to do, what are they not able to do. Second, they get an email a day prior to prep for the visit, right? So make sure your phone is charged or your device is charged. Make sure you're wearing relaxing clothing. Don't eat a heavy meal before showing up for your appointment. A light snack 1 hour before so you don't have hypoglycemia associated dizziness. And then we actually have them we keep an eye on if there are any hazards at home, physical hazards, emotional hazards. So like even the yellow flag portion, we just tell them to keep an open space. I think we tell them keep a bed with 2 pillows ready for BPPV testing and treatment, right? In case that is but we always say, make sure you have access to a bed and 2 pillows. So we prep them to the best capacity well, but sometimes the prep fails and having extra time helps. So our visits are a little bit longer just to cover everything, and setting expectation with the patient, because this is new for us, it's new for them. So there's a lot of ambiguity around. And so what I do is I say, hey, I'm going to chat with you for the next 30 minutes. Please grab yourself chill water, like cold water, or relax yourself. We're going to talk for next 30 minutes. There's going to be no testing at all. Then we will do some eye exam, then balance, then we'll do BPPV testing based on what you present, or maybe we'll skip something if you look comfortable. So we break it down for them, and that makes it usually a successful visit because they know what to expect. Of course, the device falls and they can pick it up. Suppose they're very, very anxious. That is another one, like when they're off the roof anxiety. That's when I would just kind of do more education and not push them into the exam. Like, for example, that 3PD Emily case, I wouldn't do further testing when she's sweating already with the first balance. So keeping your eyes, I'm going to say, open for non-verbal cues of what not to do is very important as a clinician, so that you don't land up losing the patient forever. Is what I would cover. But I think usually for BPPV testing, if I don't have anybody, I tell them landscape mode, keep your nice smartphone selfie camera, nose aligned with the camera, because most of the smartphones have camera here. They don't have it in the center, and everybody will keep it like this, and that doesn't help. So usually we tell them keep it nose aligned, and then do BPPV testing, lie down and show me. And they're excellent. Like, at least I'm blessed to work with people who have smartphones, and that's why I was curious with John Sir's case. Like, how do you do metronome with the armor?
Oh, that was lovely. And that is actually really thoughtful, like taking care of each and every minute thing, like kudos to you. Okay, so I think here we come to the end of our panel discussion. So I would extend my sincere thanks to all the panelists. Like, despite your busy schedule and despite the time zone differences, you took out some time to make this event successful. So thank you very much. All the cases were really wonderful. Thank you to Dr. Kapoor, who is principal of Sancheti College of Physiotherapy, for his constant support. Thank you to the entire Physio TV team, especially Tushar sir, Neeraj sir, and all the rest of the Physio TV members. And of course, special thanks to Dr. Sona Kolke for working really hard to organize this panel discussion, coordinating with each one of you, and of course, never failing to motivate and inspire us. So thank you, Sona ma'am. And lastly, I would like to thank all our Physio TV viewers. And so this webinar and this panel discussion was brought to you by Physio TV, and you can subscribe the channel for regular updates. So I, Dr. Franny Nathani, sign off for the day. Thank you.
Thank you.
Bye.
Bye.
Thank you so much. Thank you so much. Thank you so much, Sona ma'am, Dhara ma'am.